Hello and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Nicole Rochino. Today's episode features Dr. Shaji Kumar from Mayo Clinic in Rochester, Minnesota, providing his thoughts on some of the most interesting findings related to the clinical use of bispecific antibody therapies for relapsed/refractory multiple myeloma that were presented at the 2024 annual American Society of Hematology meetings in San Diego. This episode is part of a larger educational program titled Refining Therapeutic Approaches in Relapsed/Refractory Multiple Myeloma, Expert Guidance on Bispecific Antibody Therapy Optimization. For more information on Dr. Kumar, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the expert has to say about this important topic.
Today, I'm going to discuss a few abstracts related to bispecific antibody therapy in multiple myeloma that were presented at the recent annual meeting of the American Society of Hematology. Bispecific antibodies is a new class of therapy for multiple myeloma and has shown remarkable efficacy in the management of relapsed and refractory disease. Currently, we have 3 different bispecific antibodies that have been approved and is currently being used in the practice. 2 of them, teclistamab and elranatamab, are targeted towards BCMA on the myeloma cells, while the third one, Talquetamab, targets a protein called GPRC5D on the myeloma cells. All these bispecific antibodies have shown similar efficacy rates with about 60 to 70% response rate in patients who have become refractory to the currently used medications, including daratumumab, immunomodulatory drugs like lenalidomide and pomalidomide, as well as patients who have become refractory to the proteasome inhibitors like bortezomib and carfilzomib. The side effect profile also appears to be quite similar across the bispecific antibodies. Despite the high response rates, the median time to progression with these bispecific antibodies when used alone have been in the order of about a year to year and a half, depending on the different studies. There's been significant interest in trying to optimize the use of these bispecific antibodies in the treatment of multiple myeloma, both from the perspective of increasing the efficacy with this class of agents, but also decreasing the toxicity in order to make it more widely available to patients. One approach to improving the efficacy of bispecific antibodies have been to combine them with standard anti-myeloma therapies like the anti-CD38 monoclonal antibody or the immunomodulatory drugs. In the Majestic-2 study, cohort A, the combination of teclistamab with daratumumab and pomalidomide was explored, as was done in the TRIM2 studies. One of the presentations at the ASH specifically looked at the group of patients who were treated with the combination of teclistamab with daratumumab and pomalidomide. In both these studies, there was a step-up dosing followed by the full dose, and the daratumumab was used in the standard dose of 1800 milligrams and also pomalidomide at 2 or 4 milligrams. Overall, there were 27 patients who were treated across the 2 studies, 17 from Majestic-2 and 10 from TRIM2. And these patients had all been exposed to the standard of care agents, particularly the immunomodulatory drugs and proteasome inhibitors. Overall, the median number of lines of therapy was about 2 lines of therapy. When you look at the toxicity of this particular combination, the most common adverse event that was noted was hematological toxicity, particularly neutropenia. In addition to the hematological toxicity, some of the common side effects that we see with the bispecific antibody, like cytokine-release syndrome, was also observed, predominantly grade 1 or 2, but while grade 3 and 4 events were pretty uncommon in the setting of these combinations. All the events are resolved as well. And grade 3 and 4 infections in particular were seen in about 2/3 of the patients combined across the 2 studies. The regimen was quite effective. The responses were durable, with many of the responses lasting beyond 2 years and up to 3 years in some of these patients. So this is an exciting combination based on a rather limited number of patients, but certainly provides some exciting initial data of the combination of teclistamab with a anti-CD38 monoclonal antibody as well as immunomodulatory drug. It is important to note that the combination of daratumumab and pomalidomide has been studied before in the relapse setting and has shown to be effective. And this triplet regimen here appears to increase the activity of the anti-CD38 with pomalidomide combination. There are ongoing clinical trials that are continuing to explore the various combinations of teclistamab with the anti-CD38 monoclonal antibody as well as the immunomodulatory drugs. Another important study that was presented looking at the role of teclistamab in relapsed myeloma came from the US Multiple Myeloma Immunotherapy Consortium. While clinical trial data was used for the approval of these therapies, there is limited data available from the real world setting when patients have been treated with teclistamab. So the consortium has been collecting data on patients receiving a variety of different immunotherapy, including CAR Ts and bispecific antibodies. Overall, there were a total of 385 patients who were treated with teclistamab in the real world setting as a single agent based on the current approval. The majority of the patients were triple class refractory in both the age groups, and over half of the patients had previously received an autologous stem cell transplant, with nearly half of these patients having received a prior anti-BCMA targeted therapy. When you look at the outcomes, the cytokine-release syndrome, the frequency was about 50 to 60% in this patient population. Majority of them were grade 1. Grade 2 to 4 toxicities were seen in only about 10% of these patients. Nearly half of these patients, or a little less than half of the patients, received tocilizumab for treatment of cytokine-release syndrome, and about a fifth of the patients received corticosteroids as well. Neurological toxicity like ICANS of any grade were observed in about 15% of these patients. And again, a majority of them were grade 1. The major cause of death in this particular cohort of patients was myeloma disease progression, followed by infection being the second most common cause. When you look at the efficacy of this regimen, you can see that the overall response rate was close to 60%, comparable to what we have seen in the initial clinical trials like the Majestic 1 study. The response rates were a bit higher in the older patient population compared to the younger patients, but also the older patients were less heavily pretreated compared to the younger patients in this particular cohort. When you look at the median progression-free survival, it was roughly about 7 months in this cohort, bit lower than what was seen in the Majestic 1 trial. And again, as expected, the older patients had a better progression-free survival based on the less intense therapy that they had received before. The median overall survival for the younger patients was about 16 months, and for the older patients over 75, it was not reached. Now, when you look at the various factors in terms of their impact on survival outcomes, the age certainly did not seem to impact the progression-free survival or overall survival. As what we have seen with the previous studies, the presence of high-risk disease characteristics like extramedullary disease and plasma cell leukemia appear to drive the early progression seen in some of these patients. So teclistamab, based on this large cohort of patients treated in the real-world setting, appears to be holding up in terms of their response rates. The progression-free survival may have been a bit less than what we saw in the clinical trial, but again, given that the majority of the patients who were treated in the real world setting could not have qualified for the clinical trial, makes data particularly relevant to our day-to-day practice. Now, in addition to teclistamab therapy, there are other bispecific antibodies and other BCMA-targeted therapies that are being explored, including the antibody-drug conjugates. It is unclear how patients who have previously received an anti-BCMA-directed therapy will respond to teclistamab. At least some of the initial small cohorts had suggested that prior BCMA-directed therapy can negatively impact the outcomes seen with teclistamab in patients with relapsed myeloma. So the US Multiple Myeloma Immunotherapy Consortium looked at their large database in order to understand the impact of prior BCMA therapy on the efficacy of teclistamab. So they identified a total of 385 patients who were treated with teclistamab in the real-world setting. Nearly half of them had prior BCMA-directed therapy, and the other half did not have a prior BCMA-directed therapy. When you look at these two cohorts of patients, they were quite similar, except for the fact that high-risk patients appear to be more enriched in those patients with prior BCMA-targeted therapy. Again, likely a reflection of the fact that these patients had higher risk disease and ended up getting some of the more newer therapies much earlier in the course of the disease. Majority of the patients, particularly in the prior BCMA-directed therapy, had prior autologous stem cell transplant. Now, when you look at the types of prior BCMA-directed therapy, nearly a quarter of those patients were treated with an antibody drug conjugate, mostly belantamab. Nearly half of the patients had received a CAR T-cell therapy, predominantly idacaptogene peglosil, and then some of the patients had also received two BCMA-directed therapy and a couple with three BCMA-directed therapy in the past. Some of these patients are on clinical trials with a variety of different BCMA-targeted therapy as well. Now, the median time from the last exposure to the prior BCMA-directed therapy was roughly about 260 days, or about close to 9 months. And when you look at the safety outcomes in this cohort of patients, the exposure to previous BCMA-targeted therapy did not appear to have any impact on the toxicity profile. Nearly 60% of the patients had any grade CRS, mostly grade 1 or 2, and the use of tocilizumab for CRS was quite low in this cohort of patients. Yeah, when you look at the ICANS, nearly about 10 to 15% of patients had ICANS or the neurological toxicity, predominantly grade 1 or 2. And the hematological toxicity profile appeared to be quite similar across the group of patients, as was the cytopenias. Infections appear to be a bit more common in patients who had no prior BCMA-targeted therapy compared to the ones who had prior BCMA-targeted therapy, and may reflect the use of some of the infection prophylaxis methods that may have been instituted as part of their initial BCMA-targeted therapy use. In terms of efficacy, as one might expect, the patients who did not have any prior BCMA targeted therapy had a better response rate of about 62%, which is quite comparable to what we have seen with teclistamab in the previous studies. The overall response rates were lower at 49% in those patients who were previously exposed to BCMA-targeted therapy, though the proportion of patients within this that achieved a deep response, like complete response, appeared to be quite comparable. When you look at the response rate by the type of BCMA-targeted therapy that the patients had received, those patients who had received an antibody drug conjugate or CAR T-cell, both of them appear to have about 48 to 51% response rate. Even though quite small, there were 8 patients who had prior bispecific antibody, and for those patients, the overall response rate was only about 12.5%. However, this data should be taken with a bit of caution, given that it's a very small and probably very highly selected group of patients who went from one bispecific antibody to the next bispecific antibody. And another important finding from the study was that the patients who responded to the teclistamab better were the ones who had a longer time from the previous BCMA-targeted therapy exposure. And this, I think, again, makes sense, and it's quite similar to what we have seen in the setting of other therapies in myeloma, where we have used 2 different drugs from the same class of agents. The median progression-free survival was about 8.2 months for those with prior exposure, without the prior exposure, and 4.6 months for those with prior BCMA-targeted therapy exposure, again, reflecting the reduced overall efficacy in those patients who have previously been exposed to this class of therapies. The overall survival rate also appeared to be a bit inferior for those patients with prior BCMA-targeted therapy. But again, I think as we saw with the disease characteristics, some of it may have been driven by the fact that they're fundamentally higher risk patients who had previous exposure to BCMA-targeted therapy. So this large real-world study shows that you can still get responses to teclistamab in patients who have previously been exposed to BCMA-directed therapy, particularly antibody drug conjugates and CAR T-cell therapy. And these responses certainly appear to be much better among the cohort of patients where the exposure to the prior BCMA-targeted therapy was much more remote. So waiting for more length of time between sequencing BCMA-targeting therapy may be appropriate, a hypothesis that clearly needs to be tested in prospective trials. In addition to the teclistamab, as was mentioned, we have other bispecific antibodies that are being approved for use in the clinic. Talquetamab is a GPRC5D targeted bispecific antibody that have shown comparable efficacy and in the setting of relapsed myeloma, but with a different toxicity profile compared to teclistamab. Now, one of the biggest challenges taking patients to CAR T-cell therapy has been the ability to control the disease between the lymphocyte collection and the manufacturing of the CAR T and the infusion of the CAR T product. Now, there's clearly some concern if we use a BCMA-targeted therapy like teclistamab or an antibody drug conjugate to control disease between lymphocyte collection and the CAR T infusion, it might affect the efficacy of the CAR T. So there has been interest in trying to use something like Talquetamab, which uses a separate or a different antigen for targeting for the purpose of rapid disease control prior to going to CAR T. And this is an important aspect because we know that patients tend to have more toxicity, particularly neurological toxicity, when they go in with a higher tumor burden, and also appears to have lower efficacy outcomes in the long run. So there's been significant interest in trying to use talquetamab as a bridging therapy between lymphocyte collection and administration of the anti-BCMA CAR T-cell therapy. So this particular study that was presented at the recent ASH looked at a cohort of 77 patients where talquetamab was explored as a potential bridge to CAR T. 65 of these patients actually went on to get subsequent CAR T-cell therapy. A small proportion of patients had prior BCMA-targeted therapy. These patients had a median of 5 prior lines of treatment, and the majority of the patients, 50 out of the 65 patients, had actually intended to receive cilta-cel, and the remaining patients ida-cel. Now, amongst these patients who received the talquetamab, the overall response rate was about 62%, and subsequently to the CAR T, the overall response rate was nearly 95%. And the talquetamab bridging was associated with clearly very good disease control and the ability for these patients to go on to receive a CAR T as intended. The toxicity profile related to talquetamab was quite manageable, and most of the skin and nail toxicity that was observed was mostly grade 1 or 2, and there was complete resolution of the talquetamab-related toxicity. And there did not appear to be any difference in terms of the toxicity profile for the CAR T-cell that was subsequently administered. So this particular retrospective experience clearly provides support for use of talquetamab as an effective disease control mechanism or approach in patients with a rapidly progressing disease prior to going to CAR T. Majority of the patients were able to proceed to CAR T infusion, and the toxicities associated with talquetamab appeared to be quite manageable as well. Finally, I think one of the biggest barriers to use of the bispecific antibodies in the community setting has been the high rates of CRS, even though they tend to be mostly grade 1 or 2. So there has been quite a bit of interest in trying to see if we can use agents like tocilizumab that we use for treatment of cytokine-release syndrome as a prophylactic strategy given prior to treatment with bispecific antibodies. So a single-center study that was presented at ASH looked at a cohort of about 72 patients who received prophylactic tocilizumab prior to receiving bispecific antibodies. The majority of the patients were treated with teclistamab, some with elranatamab, and some with talquetamab. The overall rate of CRS was quite low in this cohort, only 14%, and the ICANS rate was about 8%, and this is quite low compared to what we have seen in the previous studies where no prophylactic tocilizumab was used. The use of prophylactic tocilizumab did not seem to affect the response rate or other toxicities. The best overall response rate included about 38% of these patients getting a complete response and another 18% receiving a partial response. So a total overall response rate of about 56%, quite comparable to what we have seen with use of these bispecific antibodies in the setting of relapsed refractory disease. So certainly quite interesting data, whether we should be using tocilizumab in everybody or in a more selected fashion based on their underlying risk of developing CRS or cytokine-release syndrome needs to be studied in prospective trials. So in summary, these studies again highlight the utility of a new therapy like bispecific antibodies in the treatment of relapsed refractory disease and the ability to improve on the outcomes by combining it with the other common standard of care agents. And furthermore, the ability to decrease some of the toxicities like cytokine-release syndrome will eventually lead to wider adoption of this therapeutic modality in the community setting. Thank you so much for joining us today. We hope that you found this useful.
Thank you, Dr. Kumar, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Refining Therapeutic Approaches in Relapsed/Refractory Multiple Myeloma, expert guidance on bispecific antibody therapy optimization, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.